Dr. Kumar, who is going to talk to us on the new revolutionary technology Z8, which he's been using for a period of time. Dr. Kumar, as you are well aware, is one of the leading surgeons in Mumbai, has done high volume surgery, does exceptional work, a really beautiful surgeon, and we look forward to his talk. Who's going next? Okay.
Good morning to you all, and I would like to thank Professor K.K. Mehta and the rest of the team from Zimmer as well as AIOC to have given this opportunity to me. So I'm going to talk about my experience about a few months now with the Z8. I had the Z4 for 8 years, and then I decided to go in for the Z8. So what does it do? Yes, it does LASIK flaps. It does clear, which is a lenticule extraction like smile. It does pockets. It does therapeutics. So intracorneal rings, penetrating keratoplasty, lamellar keratoplasty, and PKP. And cataract, it does clear corneal incisions, arcuate incisions, capsulotomy, and lens fragmentation. So technically, it's one unit which is mobile and can perform all the surgeries with good efficiency. So I'll show you some of the videos. So this is how it sits in your OT. I have it in my LASIK OT. You can take it back to the cataract OT, whatever is convenient. You can do whatever you want. So let's look at the cataract part of it. So I'm going to show you some videos so you know exactly. Now, how do we know that what incisions we are making are perfectly accurate? So I first do a toric mark. Once I do a toric mark, I go ahead and then make the patient lie down. As I mentioned, I have it under the LASIK OT. I'm doing it under the MRS. So my mark, sometimes you can either put methyl on it, or you can go ahead and mark this further. And once this is done, we make sure that there are two-step procedure as far as the cataract step goes. In LASIK, you can do one way. So this is step 1 and this is step 2. So first we put the dock, and once the dock is done, the handpiece is docked on. Once the handpiece is docked, we go back to the screen where it takes a still image. Once the still image is done, you build up the vacuum, the handpiece is perfectly in place, and once the docking is done, it checks for centration. The centration is good, you get a green offset. So this is in real time, and then it goes ahead and checks for capsulotomy, and then you can adjust your height of the capsulotomy, whatever you want. You can take it up, take it down, like any other femto laser. Then this is the lens fragmentation, and this is the incision. So you can see that my marks are now perfectly aligned, okay? And this is the incision. I also do side ports with the same laser. And this is the actual happening of the lens fragmentation. It does little differently than the other femtos which are there in the market. So you have lens fragmentation first, and then the capsulotomy, and then the clear corneal incision. So this is as far. Now let's see how it appears on the eye. So this is step 1, step 2, and then step 3. So let's see whether these incisions are accurate as what I want or they are not. So I have the virion on, and the triangle in the virion says where the main incision is supposed to be. So what I'm trying to say here is it's extremely accurate. I wanted the incision to be at 160, and it is exactly at 160. So you can see half the incision was on one half of the triangle, the other incision on the other half of the triangle. Once that is done, you go ahead and put methyl or whatever viscoelastic you want. Once that is done, you can pick up the capsulotomy just because it's free floating. This is opening of the side port. So it's truly bladeless. I'm not using any blade. This is just a small inserter which removes. And once this is done, you can just go ahead and remove the rhexis, which is freely floating. And then comes to the fragmentation, which is already done. I do a 8-segment fragmentation with a central ring. Here what I'm trying to show is the neat, clean cut of the fragmentation. And that shows how well your energy is applied to the side cut. So you can see the side edges. You can see the side cut very, very clean. I'll show that under high magnification on the last piece. I don't want to waste time here because it's just like routine phacoemulsification. And this is what I'm trying to show here. So again, separate. Again, as I mentioned, I have 8 pieces, a central circle. And here I'm doing on the high magnification to show how clean that side cut is. So the sector formation is extremely clean. It's a straight sector formation magnification, and there are no bridges actually at all. You can again see this under high magnification, and it's complete. So again, I'm showing you this. See the clean cut that you can see there. So this is as far as the sector formation is concerned, like any femto that is there in the market. Then proceed with the bimanual IA, and then go ahead and put a toric IOL. It's really a mobile unit, you know. I mean, can you imagine me just pushing this into my OT? I mean, it's unbelievable. You have that expression when you buy it. So you already paid for it. That expression comes when you pay for it. And it's a single person can push this from one end to the other. Another big advantage, it's not temperature dependent. I'm not saying do it under an off OT or in a humid environment and go and do it in Sahara Desert or something like that. But it will work. And it's not dependent, so it's not going to shut down. I had the catalyst system before. If you have a temperature variation of 2 degrees, it will say temperature not correct, and it will shut down. It will go into a default mode, and that's the big disadvantage of that. So question here is about accurate placement. So you can see the triangle of the virion. Half the incision is on one side of the virion, and other half incision is on the other side of virion. So this is another big advantage of the whole technology. You can see, again, I don't want to waste time, and this is the rhexis, which is perfectly round. You just pinch it like you pick up a handkerchief and just take it out. So it's as simple as that. You can have various methods, various segments, more segments. We all know the advantages of femto. I don't want to go into the depth of that because here the system is only on that. Does it cut arcus? So I was a little confused. Will it cut a white cornea? Okay. So here you are seeing it's not a very dense arcus, but yes, there is an arcus. And I'm just using a Sinskey hook to open my main incision. So yes, you can see that I've just opened the main incision. So the bottom line is, yes, it does cut arcus, and it does do very, very well. So that confusion is completely over, and the rest of the steps remain exactly the same. Go ahead and use the fragmentation. Coming to the next use, as far as I'm concerned, is LASIK flaps, intacts, and pockets. So I'm going to show only one video of mine about clear. This was my second case of my career. Okay, I have done workshop with Kudlu. So I'd done 10 eyes before with Kudlu. So it's called clear corneal lenticule extraction for advanced refractive correction. So it's called clear, and I say see clear with a smile. So you don't need to market anything else. This tagline works extremely well. It has shortened, I have shortened my learning curve. So you may call it a cheat, or you may call it an experience, whatever you want to label it as. What I'm doing is I'm doing 2 incisions. One incision is anterior, one incision is posterior. So this will only go anterior to the lenticule, this will only go posterior to the lenticule. So this shortens my learning curve completely, and I don't need to prove to myself that yes, I can do 1 4mm and divide it into this. So this is in real time. There is no editing, there's no fast forwarding. It may be a little slow for some of you experienced surgeons here, but as time goes by, I'm sure my speed will pick up. Now this is going posterior. As you can see some of the bubbles above the spatula. The other side was the anterior dissection. Now one little different step that I do as far as I'm concerned is that when I separate the anterior lenticule, now the next is the separation of the anterior lenticule. In this area, I will not press the lenticule down. So I will leave it attached to the anterior part, because that's where my space is for the posterior lenticule. So you can see that here I am not going to dissect. This is my posterior lenticule dissection, but I have dissected the anterior lenticule all around. And that may be a little precaution that I am taking in the initial stages as experience goes, so it will be easier. So now I am going to dissect the posterior lenticule. And then when I remove the lenticule, obviously you expect some attachment in this area, because that's not where I have separated the anterior lenticule. But that's okay, because if I separate the anterior lenticule there, I'm actually pushing the lenticule down, which is what I don't want, because that may make my posterior dissection plane finding a little difficult. So I've done this, I got my posterior plane, so 1 sweep, 2nd sweep, and then that's done. And question is, just pull the lenticule out. Once you pull it out, wash, don't wash, it's up to you. Depends on what you want to do and how it really works. So now I'm just going to show you, grasp the lenticule and just see the little bit of dissection here which was not done. So you need a little bit of separation and a shearing force there. The rest of it was completely well dissected and works extremely well. So you saw that, it just comes out and it works extremely well. So coming to the next step, now this patient came to me for a cataract. If you had to do a femto for him, it would be extremely difficult on any other system. Because if you have the catalyst or any other system, it has a fixed bed. You can't turn that head or you can't turn that at all. So now the question is how to take this fellow for, and this is all he can get his neck up. Now the question is, how will you do a femto cataract for this patient? This is what actually happens, but I planned it. I took the femto from the LASIK room onto my cataract room. I have a bed which is very good, which you can turn in various directions. You can see that this is all the head can actually go. But so you put pillows, everybody knows that you put pillows below the bum and then take the legs up. You hold on to him, and once that is done, you'll get the position of the head. Now here the biggest advantage is that your whole arm of the system is adjustable. So here I'm using the speculum to keep it a little easier, and once the speculum is done, I just take the whole body. Another big advantage of the Z8 is you can move the arm up or down. So you can see that the arm is being moved up or down, and that makes the adjustment for me much easier. So once this is done, I'm getting it perfectly. The same steps what I showed you will be taking place. So I'm actually being able to do all the steps in this patient. And now let us see how it looks on the eye. So you can see that yes, my incisions are done. My side port is made. My main incision is also done. Fragmentation is also there. Once that is done, we can go ahead and do a bimanual IA. Once the bimanual IA is done, we can go ahead and put, I think it was a toric lens for him, yes. So I do have the video on to my microscope. Sometimes this happens. The haptics fall in love, and they do need a special effort sometimes to be separated. So this case, what I thought was a patient with kyphosis wanting to do a Z8 would not be possible in any other system you have under that kind of a bed system. So having that bed, having the Z8 mobile unit, you can adjust the arm the way you want. I think it works beautifully well. So I think this is unbelievable, and I thank you all for your attention.
Thank you very much, Dr. Kumar. I quite agree with you. It seems to be extremely versatile, and so certainly the doing the smile component part, where you separated the anterior and posterior lenticle, shows the level of accuracy of the laser, which really is quite impressive. And the one advantage is, in a small little unit, you can manage to get both the femto part as well as the femto cataract part, as well as the femto LASIK part, which I think has made all the difference. Congratulations, and you're getting it, and I'm sure you'll find more and more uses of it. Thank you very much. Our next speaker is going to be talking, Dr. Nitin Deshpande is going to be talking to us on iStent Inject Glucose, the next generation mixed solution for glaucoma management. It literally is something which is now all over the world. And we're so happy that we have Dr. Nitin with us, who's going to talk to us and tell us more about this new procedure, which really makes all the difference. Dr. Nitin Deshpande.
Thank you so much. Thank you, sir, for allowing me to speak on this. So I'm going to share my early days and early experience of using iStent and iStent Inject. And I want to thank AIOC and Saikat especially for helping me in this journey. All these years we have our traditional options of eye drops, and which we know that we have to add on multiple drops on patients, and at the end of 6 months only 50% of your patients are really using those drops properly. Then is a laser trabeculoplasty, which is an adjuvant to your medical therapy, but we all know that over time effect of trabeculoplasty wears off and you have to repeat it. And then we have these conventional surgeries like filtering surgery, trabeculectomy, and tube shunts, which are gold standard surgeries. They have proven their worth over years, but we would generally reserve them for more advanced glaucomas. So we want some solution for mild to moderate glaucomas, and that is where MIGS fit in. So is microincision glaucoma surgery, and iStent is a type of it. And you can see there are different glaucoma surgeries, ab externo, ab interno, and iStent is a Schlemm's canal based surgery, and it's ab interno surgery. Now we all know this trabecular meshwork structure, and the one that troubles us most is juxtacanalicular meshwork. And what we do by doing all these mixed procedures is either we cut it or we implant devices into it to bypass this juxtacanalicular meshwork so that aqueous can get access into the collector channels. Now, there are various types of ab interno Schlemm's canal surgeries, the ab interno trabeculectomy or trabectome. Then what we do, iStent is basically we are bypassing trabecular meshwork. And then ab interno trabeculotomy or GAT, which we use a suture to just disrupt 360 degrees trabecular meshwork, or dilatation with the ab interno canaloplasty. So the cheapest option we have is a suture GAT, which is just a 6-0 proline to treat it. Now, what is the goal of using these MIGS is that this procedure should be ab interno so that your conjunctiva is spared. It should be minimally traumatic, efficacious, quick, and it should have a very high safety profile. So iStent is a very small micro device made up of titanium, and it is a MRI compatible device which we are going to implant into the trabecular meshwork that the snorkel is facing us. So I'll share my video with you as we go along. And the newer generation iStent is called iStent Inject, where we use two little tiny devices. Those are implanted into or rather punched into the trabecular meshwork. So what are the indications? Generally, I would target mild to moderate glaucomas, although there are publications on more advanced glaucomas also. I would look for patients which are medically intolerant to the medications because of ocular surface disorders, those who have poor compliance and who would benefit from a reduction. And most important is you should know gonio very well, because only when the angle is nice and open and when you can see all the trabecular structures, then only you can go and plan this surgery. And preferably I would combine it with the cataract surgery, because post-cataract your angle really opens up well and procedure becomes easier. Although in initial phases I have done few phakic cases and they went pretty smoothly. So what is the problem with drops is they have a lot of side effects, there are compliance issues, then there are fluctuations in IOP. Then it's forgetfulness because most of our patients are old, and there is a lot of significant economic impact also due to use of, especially in patients on maximum medical therapy. And OSD is a very common problem. Nearly 60% patients have OSD. So you add more than a drop. Nowadays I just start teardrop straight away, because I know most of them have a OSD in the form of either blepharitis or say inflammatory reaction. Most of the patients have inflammatory test positive, and all this is because of BAK in the drops. And good part about this procedure is you're actually saving the conjunctiva. So it's possible to do further glaucoma surgeries in future. And even if you do one iStent procedure, you can always do other mixed procedures on the same patient, because most of your trabecular meshwork is still intact, and not like GAT where you're just avulsing whole 360 degrees. So there have been a lot of trials, especially this was a pivotal trial for iStent Inject, and this was conducted over 24 months. And you can see the primary endpoint of more than 20% reduction was achieved in a higher percentage in Inject plus cataract cases compared to the blue one is only cataract and phaco cases, and the green ones are iStent plus phaco cases. So you can see that more patients had more than 20% reduction, and you can also see there was a higher reduction in intraocular pressure in iStent group. You can see there was a 31% reduction from the baseline in iStent group, and you can also see that unmedicated IOP less than 18 was higher in the iStent group compared to the phaco group. So rather than doing only phaco, adding a iStent to your surgery definitely made a difference. And 84% of Inject patients were medication free at the end of 2 years. Safety profile, it was found to be as safe as a phaco surgery. Another study that of iStent, the previous one was about iStent Inject, and this is about iStent in open angle glaucoma patients with single medications. So there was a 46% reduction, and this study was conducted over 4 years. So that was pretty long period, and 95% of your patients were medication free. So that shows that it's really effective. And the another thing is it's been a very long-term study. So 4 years is a significant duration, and IOP reduction was also quite significant. And when you compare with the travoprost group against the patients who had 2 iStents at the same go, you find that overall IOP reduction and was better in the group which had 2 iStent two iStent implants compared to patients on medications, and we also know that medication patients would definitely have more OSD compared to the iStent group. So treatment success was much higher with a iStent group. Then this was a meta-analysis which again was a long-term study of 60 months, and you can see there is a 30% reduction in IOP and almost 7 millimeters of mercury of IOP drop, which is a very good result. OSD, there was a major impact on OSD. As you can see in the next slide, there was a 50% improvement in the tear breakup time, staining reduced, and even hyperemia reduced. So OSD I find to be a major issue in my patients, especially those who are on 3 or 4 drops, and their life is really miserable because of all these drops. And if we can reduce them with a minimally invasive surgery, there is nothing like it. There was one interesting study I found that even post-failed trabeculectomy, you can do these procedures and have a significant drop in pressure and medications. When you compared iStent and iStent inject is found to be a little more effective. And an interesting fact is 70% of both groups became medication free at the end of 6 months. So although iStent inject is little more effective, even iStent by itself is a very effective implant. Now, just to give you little tips about the surgical procedure, so I suggest that you start practicing on your regular cataract patients, because it takes a little while to really learn to look into the angle. I started practicing almost for a month on how to rotate the head away from you, how exactly to tilt your microscope. So basically you're looking parallelly to the iris into the angle. So you have to tilt microscope towards you, and you have to tilt patient head away from you. So once you get this, procedure becomes very easy, because it's all about visualization, because that device is it's a very micro device. So once you get your position right, I would say your 70% things are done. And another important point is use high magnification, because unless you are very sure where is the trabeculum and where you are inserting it, you will not get a success. So high magnification is important. Another important thing is a good cohesive visco. The care group makes 1.8% Helon, which is excellent for this procedure. So you fill the chamber as well as apply some on the cornea. And this is a lens. Now that gel works as a coupling agent, and this direct gonioprism is provided by the company along with the stent, and you can now see the trabecular meshwork there. At the end of cataract, you will get a red reflux into the trabecular meshwork. So identifying it becomes very easy. And you can see there is a tiny device at the end of the pencil-like thing that I'm holding, and you just tuck it in. So once you do 1 or 2 procedures, you'll get a good feel. And once you're tucked in, just press the button and the device is released. And you can see that snorkel is facing towards you, and implant is perfectly placed. And also you will see the reflux of blood through that snorkel. So you know you're exactly in the Schlemm's canal. So procedure is pretty quick now. This case took hardly 5 minutes to do. Very comfortable for the patients, and recovery is as good as your cataract. So you get little blood reflux and slight hyphema when you're closing, but don't worry, next day you will not see it. And now you can see in the high mag, you can see that snorkel facing towards you. This position is required because if it is dipping down facing towards iris, your iris can go and block it. And this is a quick video of a iStent inject, where I have finishing the cataract surgery, and same procedure. However, this is a little different because you have to punch 2 devices into the trabecular meshwork. One thing you have to learn is how much to press. So you press a bit, come back, and then release the button, and it goes like tuck and tuck. So you have 2 devices, and they are really tiny. So make sure you see them, keep seeing that you don't lose them. And after, you can see there is a nice blood reflux, and my device is perfectly into the trabecular meshwork. So first is done, and the second one also goes in. So so it looks easy, but it takes a little while to really get all the things in place. And I have done 9 cases. Purposely I left out one because I had discussed with the patient that it may not work great for her. She was a ENT surgeon, and she knew that I might have to proceed, but she still wanted to have a go. So it did not work very well in that patient. Otherwise, I've done 8. Out of that, almost 2 patients were phakic and 6 were pseudophakic. That is, that combined with the cataract surgery. And so 8 patients in all. And you see there was a almost 20% reduction in IOP over 1.5 months that I'm seeing them now. And you can see that even medications have reduced to 16% in this patient. So even that's a very initial result. So, and I have had decent results, and I'm sure as I get more number of patients, I'll be more clear to share my results with you. So thank you so much.
That really was an excellent display. I think mix is now soon coming in a big way. But the most important thing which you highlighted and which I think is a take-home message for any of you who are planning on starting it is first learn to recognize the Schlemm's canal. And you have to do that by tilting the microscope almost 180 degrees away, because you're seeing along the corneal plane to be able to see. And as you said it accurately, it takes quite a while before you can manage to really do that well enough. Once you do that, it's not difficult. Actually, number one MIG, what do they call it, the first model? Yeah, the iStent, the plain iStent one was the easiest one to insert. The iStent, I think it's all a question of time before it comes in. But it is something which you need to look onto, and certainly if you're a glaucoma surgeon, it has to be a part of your armamentarium. Having said that, I would now like to invite Shreyas to give his talk on the one-step refractive solution.
Nitin, sir, I'll say a statement. I can say something?
Sure. Of course you can.
Very nice talk, very nice videos. Just for your information, now there are new microscopes available where you press a button and it turns 35 degrees automatic.
Which one is that?
Leica.
Achha, Leica.
It's got a memory specially made for people like you.
Nitin, any complication in terms of extrusion or anything post-op?
One iStent patient had a single K formation.
Okay.
Otherwise,
And do you do any special pre-op investigation other than gonio, or do you mark something or site where you want exactly?
you can't mark it. You have to always do infero-nasal,
Okay.
because that is where you have most of the collector channels.
And any particular bleeding or anything when you insert?
Actually, bleeding is good because you know you are in place.
Okay.
So you have a little 1 or 2 drops coming out, but next day you will not see it.
Only one thought, that when you remove the viscoelastic after you've done the procedure, it doesn't disturb that at all, right?
Not at all, but you will see the blood reflux coming. So
That's
you know
okay.
it's good.
And do you reduce the bottle height during viscoelastic removal?
It stays beautiful.
It doesn't come off or something, nothing, okay.
Or any specific post-op regimen for any of these
So I
patients?
just use my cataract regimen. Nothing special. In fact, if it is only iStent 2 phakic patients, I use fluoromethanol, not a...
But in terms of our anti-glaucoma medication, do you modify anything?
Now there was, either you continue same medications and reduce eventually, that's what I did. But if you really want to know effect of a stent, you should ideally stop all the medications and then increase them
Restart
as you
it.
need them. But I was a bit skeptical because some moderate glaucoma patients I did not want pressure to shoot. So for first few cases I have just continued and then reduced some medications.
Mhm.
But if you really want to know, then it's better to wash out and see the effect.
Okay.